This is part 4 of the lecture on imaging of the eye and orbit. Okay, we've completed our discussion of ocular pathology, of pathology of the globe itself. So now we're going to move more posteriorly and talk about pathology within the orbit. So we'll talk about masses, we'll talk about the extraocular muscles, some on infection. The optic nerve, of course, deserves a little bit of time unto itself. And we'll talk about nearby pathologies such as paranasal sinus disease that might secondarily affect the orbit. And I've reserved the other category in case I think of anything else after we're done. Let's start with benign masses. Thankfully, in the orbit, benign masses are more common than malignancies. And in fact, the most common of the benign masses is a venous malformation, which everyone still refers to by its historical term, hemangioma. Venous malformation, the more proper term. Perhaps even venal lymphatic malformation, although most of these are pure venous. The second most common benign mass that we encounter in the orbit is a varix. That's just a dilated vein that often is partially thrombosed. Less common diseases include dermoids, neurofibromas, and then gliomas and meningiomas are benign masses of the optic nerve or nerve sheath complex. When you see a lobular enhancing mass within the orbit causing relatively little mass effect, that's when you should think about venous malformations, hemangiomas. Notice how lobular the enhancement is here. These are slow to fill with contrast, and so if you do sequential images on CT, you may be able to watch it fill in just like we do in the liver. Notice that although this is a fairly large mass, there's really no exophthalmos, another clue that we're dealing with a hemangioma. The lobular configuration, though, I think is the biggest clue. Here's another patient. In this patient, on an unenhanced T1 weighted image, you can see that there is laminar bright T1 signal. And in a slightly different cut, you can see again on T2 that there is laminar signal with darker signal in the central area and brighter signal around the outside. Not a lot of things cause bright T1 signal in the orbit once the fat's been suppressed. And this laminar appearance also characteristic of a thrombosed varix. Not all varices are thrombosed when you encounter them. There's another trick you can use here, which is to use a Valsalva maneuver. If you do a CT before and after a Valsalva maneuver, a varix will usually expand with the increased pressure, and you can see that discrepancy on the two images and make a definitive diagnosis. Here are a couple of additional examples of varices along the medial aspect of each orbit. You might be inclined, looking at this image, to say that there is a lipoma of the orbit. This lesion is purely fat density and well circumscribed. It looks just like a lipoma. If you are about to say lipoma for a lesion anywhere near the orbit, stop yourself and instead call it an orbital dermoid. Orbital dermoids look just like lipomas except that they're in the orbit. Can you get an orbital lipoma? It is possible, but most of these will be dermoids. Fortunately, these two diagnoses, lipoma and dermoid, are easy to distinguish clinically because the dermoid is hard and the lipoma is soft. So if you'd like to be definitive about this, call up the ophthalmologist and ask them whether the lesion is hard or soft, or if you put that differential in your report, they'll have no difficulty making a specific diagnosis themselves. Here's an example of a patient in which the superior orbital fissure has been widened and there is a well-defined benign appearing mass emerging through that superior orbital fissure and extending into the orbit, coming right along the expected course of the third cranial nerve. That's because this is a mass of the third cranial nerve and this is a neurofibroma in a patient with neurofibromatosis type 1. Remember that patients with neurofibromatosis type 1 will also get a characteristic dysplasia of the sphenoid bone shown here, as well as a large overlying plexiform neurofibroma in this case. There's a classic radiologic differential diagnosis for masses that arise from the optic nerve sheath, glioma versus meningioma. The glioma is a central mass of the nerve itself that replaces the nerve and expands the entire nerve sheath complex outward. A meningioma, on the other hand, is a peripheral mass arising from the dural sheath that crushes down centrally on the central nerve, and because it occurs on either side of the nerve, can produce, on post-contrast imaging, a tram track appearance where you can see the meningioma on either side and the nerve in between. This is an example of a glioma of the optic nerve. You can see that there is a uniform enhancing mass. There's no central spared nerve. There's no tram tracking. It's all one color through and through. Sometimes this is easier to appreciate on a coronal image where you can see that there is uniform enhancement of this mass and not peripheral enhancement around the nerve. Now look at this example of a coronal image. This is the normal side, and you can see that the optic nerve sheath complex is blending into the background on this post-contrast coronal fat-suppressed image. On this side, you can see that there is a halo of abnormal enhancement around the nerve itself. That halo of enhancement is the neoplasm tracking along the dural sheath around the preserved nerve centrally. This is the characteristic tram track appearance of an optic nerve sheath meningioma, where you can see the meningioma enhancing on either side of the preserved nerve centrally. I say preserved, it's preserved radiologically, but this is almost never preserved clinically. Now let's turn our attention to malignant masses. The most common malignant mass to arise in the orbit is lymphoma, but you can also get minor salivary tumors arising from the lacrimal gland, which is, after all, a modified salivary tumor. In children, rhabdomyosarcoma is a significant concern. In fact, any lesion near the skull base should be concerning for rhabdomyosarcoma in a child. And then metastases of the orbit. We'll spend particular attention on breast metastases, which can have a unique imaging appearance. This is what lymphoma looks like when it arises in the orbit. This is a relatively well-defined mass. It's polite with respect to the surrounding structures. It's sort of coming around the globe and not invading into the globe. Those findings are characteristic of lymphoma. It tends to be a very polite lesion as malignancies go. Notice also that it is a uniformly enhancing mass. That's also characteristic of lymphoma. Here's an enhancing mass that seems to track along the course of the third cranial nerve and its branches. That's because this is perineural spread from a minor salivary tumor, in this case, adenoid cystic carcinoma. Adenoid cystic carcinoma, of course, famed for its ability to have perineural spread. Lymphoma, also famed for that ability. Here's an example of a large mass that isn't actually arising in the soft tissue of the orbit. It's rather arising within the triangle of bone that sits behind the orbit that we call the sphenoid buttress. And like most masses that arise in the sphenoid buttress, this mass is extending into the soft tissue of the orbit, into the middle cranial fossa, and into the temporalis fossa. Intraosseous meningiomas that occur in this location can have a similar mode of spread, but this is very, very destructive, this mass, very aggressive. Furthermore, it has a friend on the other side that might clue you in to the diagnosis of metastatic disease. This is a different type of metastatic disease. Notice that in this patient there should be fat all through the orbit, and instead the location of the normal fat is replaced by enhancing soft tissue. What's really impressive about this case, though, is that all of this enhancing soft tissue is not causing any mass effect. There is no exophthalmos. In fact, quite the opposite is true. The globes have been retracted and there is bilateral enophthalmos, despite the fact that there is large enhancing mass replacing all of the orbital fat. This is a serous breast cancer, and it has a retraction of the surrounding soft tissues because of its scar-like formations. Serous breast cancer thus has a very characteristic appearance, and it's possible to make a very specific diagnosis when you see this enhancing mass filling the entire orbit, replacing all the orbital fat, and yet causing enophthalmos, not exophthalmos. Here's the same finding of metastatic serous breast cancer on MRI. All of the fat that should be present on this T1 weighted image without fat suppression, all that fat's been replaced. Here's the color of the bright fat, a little bit of residual fat there and there, most of it replaced by the breast cancer, and again, enophthalmos as the globe is retracted back by the serous nature of the metastasis. This ends part 4 of the lecture on imaging of the eye in orbit.